You must have seen that technology has really progressed and there are many things that were not present then. How much do you think technology has progressed?
We have actually progressed in leaps and bounds. Right from the understanding of the biology of cancer, we are actually on a cusp of a revolution.
In the time when medicine is advancing faster than ever, true challenge is not just discovering new treatments, it is making them reach the people who need them the most. And today's guest is the man who chose that challenge. Why are patients still reaching the hospitals late?
So when I was in the UK, 75% of those patients would present to us with early stage. 75% of the patients who I see in Bombay come to me at a late stage. We distributed 10,000 coupons for free for anyone to come and do a mammogram. And guess how many people of those 10,000 people turned up for mammogram? 20. People think if it gets detected, that means my life
Is over. What are the most commonly ignored signs in your patients?
blood coming out from any part of the body. They ignore constant cough. People ignore weight loss. Some people also ignore lumps and bumps in the body. 1 in 2 people are going to be diagnosed with cancer. 1 in 3 people are going to succumb.
Hello and welcome back to our episode. As you know, we have Dr. Sachin Trivedi. Welcome, doctor.
Thank you.
How are you doing?
I'm all right, thanks.
I want to ask you a straight question to begin with. In your experience, in all these years, you must have seen that technology has really progressed. The time that you started, there were many things that are not, effective today, and there are many things that were not present then. How much do you think technology has progressed?
See, you have actually asked a very interesting question. And in fact, just yesterday I was talking to one of my patients that whatever we used to study in medical school, when you go back and think about it and read about it, you can only laugh. At the level of understanding that we were at that point to where we are now, I can only say we have actually progressed in leaps and bounds.
Okay.
And right from the understanding of the biology of cancer to the techniques that we use to manage cancer, it has changed dramatically. Okay, and I always use this word that we are actually on a cusp of a revolution. In fact, we may be living in revolution. It's only that we don't realize it. Okay, so what we can do today is really lay out the DNA of cancer cell, identify each and every mutation or error in the DNA. We have the ability to develop drugs which we can use to target this mutation. To the other side, where we have sophisticated machines like cyberknife, radiosurgery, proton. So things are amazingly different and things are amazing. And in fact, I'll tell you, it is that, in my area of work, in oncology, we actually, and if you go to the research articles and if you want to keep yourself abreast, it's like reading a newspaper every day.
Correct.
Every day there is something new happening, and that is what I tell my patients, that there is a hope for everyone because we are moving very fast when it comes to cancer research and cancer medicine.
But doctor, if technology was that important, and of course I agree that technology has progressed as much as it has.
Yeah.
And as you rightly have pointed out that the things that you learned are not really even close to what you are actually doing in practice. But if that was the case, doctor, why are patients still reaching the hospitals, the doctors so late? Why this delay?
It's a very sad thing, and because this is a fact. Okay, I'll give you some hard data from my personal experience. So when I was in the UK, if I was running a breast cancer clinic, usually it was on a Friday, I would see hundreds of patients, at least 120 in a day. 75% of those patients would present to us with early stage. And when I'm doing a clinic now in Mumbai, Bombay, 75% of the patients who I see in Bombay come to me at a late stage.
My God.
Okay, and this is what I observed in the first 6 months of my return to the country. And I used to ponder why is that happening, and I discuss this with my colleagues and say, let's say for example, even for breast cancer, why are patients coming late, even when they know that if we diagnose it early, we can cure it. Okay, so one of the things that actually we thought maybe in the UK and the Western world, the government has a standard screening protocol. So every woman who is at an age where there is a risk of breast cancer, they will undergo some screening, such as mammogram. So that is a regular thing, and because of that, many cancers can be picked up early. Whereas in India, we don't have those kind of facilities. So I felt that maybe people don't have the resources. But the part of Mumbai that I work in South Bombay, resource is not a problem.
Not at all.
Not a problem. And in spite of that, people don't come up. So the other thing was maybe there is lack of awareness. Okay. But I thought, how can people not be aware? Because everyone is so aware about their health now.
Yeah.
So I said, let us do some awareness and let's do a campaign on mammogram. So part of this campaign, we distributed 10,000 coupons for free for anyone to come and do a mammogram.
For free.
For free. Okay, and there was a nominal 500 rupees charge, where the actual charge is much higher.
Of
so
course.
it's a registration charge, because we didn't want people to not have value for it, okay, not feel that it is valuable. So we said we'll also do a consultation for them. And guess how many people of those 10,000 people turned up for mammogram?
I don't know.
20.
Just 20. Just 20 people
20.
came out of a free coupon, which was essentially giving them a chance to get a mammogram done.
Yeah. So I think there are two reasons. One is either people are not aware, people don't understand, and even if they understand, they are scared.
They're scared to find out.
They are scared to find out. Because, my personal thought is that people think if it gets detected, that means my life
Is over.
But I like to reassure all your audience, okay? If we catch it early, that is not the case. Okay? So this is a very, very important distinction that I have actually seen.
From what you said, I have two questions. Firstly, for a country like India, we are a large country with probably the largest population in the world right now. And our cities are filled with more people than probably a European country is populated with. Do you really think it is possible, at least in today's times, maybe in the future, I hope, that the government, that the establishment, that the medical fraternity can come up with a system where it is mandatory for women, for men to do these tests, to figure out and to catch a cancer or any chronic illness at an early stage?
It's a very good question and a very pertinent one, because we know for a fact that cancer screening can save lives. And this has been proven all over the world. But you started a question about the size of the city and the population that we're dealing with. That makes it a big problem as well for the government. Okay, and I look at it from the other point of view also, from their point of view also, that we are actually living in a place where the healthcare is really unorganized, disorganized. So the kind of care that you can get in India, it can be the best in the world, and it can even be the worst in the world. It really depends on where you go. There is no uniformity.
Yeah.
And for screening and processes like screening, really it has to be done in a systematic way where everyone gets a uniform access to screening. So you can't actually say that the government will open a screening center only in South Bombay and not open it in Goregaon. That is not possible. So the government has to be uniform. For that, it has to be a big policy decision and a big policy change and a massive investment from the government.
But doctor, you issued 500 free coupons essentially, and only 20 people turned up. Even if the government tomorrow puts in thousands of crores and opens up these hospitals and centers, Do you think the stigma would let the people move away of it and come for free, even if it is for free?
See, it will take some time, but other than doing this, we have no other option. The things that we need to do is to bring this conversation about cancer screening and cancer diagnosis, cancer treatment in your normal discourse. People shy away from discussing all of this.
Right.
People would very, very comfortably tell you that, they have a kidney problem or heart problem. People shy away from this because they think there is a stigma attached to it. But I would say that there is no stigma. Having said that, I also wanted to point out to some statistics from a UK body called CR Cancer Research UK. So about few years ago, they quoted that almost 1 in 2 people, 1 in 2 people in the Western world are going to be diagnosed with cancer in their lifetime.
Especially women.
Yeah, but it applies to everyone. 1 in 2 is in half the population is going to be diagnosed with
some sort of
cancer in their lifetime. And if our treatment doesn't evolve, we're not able to give them the best care, 1 in 3 people are going to succumb.
Wow.
So can you imagine that? So
that's 1/3 of the world's population.
That is data from the Western world.
Right.
Okay? Because the rest of the world has other problems to deal with. But see, we want to become developed country, right? We want to be Viksit Bharat.
Correct.
So Viksit Bharat के साथ में विकसित देशों के प्रॉब्लम भी आएंगे.
Correct.
So along with the privileges that we'll enjoy when we become developed country, there are also going to be problems. And one of the thing is we will have more patients diagnosed with cancer in future. And we are already seeing that in
Right.
On the ground as well. If you actually ask your crew members or anyone, okay, do they know a close family friend or someone in their distant family who has been suffering from this disease? Everyone will say there's someone was there. So this is a very common disease now. Okay, so talking about it, discussing about it, understanding why screening is important, what are the treatment options available, okay, will make people aware that they should go for it. And the other thing, I may be a bit may sound a bit cruel here, but you can also have some kind of incentive and punishment kind of system. So you get screened if you want to get promotion, okay, or you're not getting screened, then you might have to, or you have a tax break only if you get screened. If you don't get screened, you don't have tax break.
Yeah, there may be a point-based system.
Yeah, because you remember, the disease is so nasty. It affects the patient and everyone around them, okay, and the society. So a working person who is actually the breadwinner of the family gets this disease. The family has to sell off everything to get them treated, okay. Then what happens is they were going in an office where a lot of things were dependent on them. They can't go. Naturally, the employer would say give it some time, okay. But their job suffers, the work suffers, the institution, organization or company they work in, that suffers, and as a whole economy and the country suffers as well. So actually it makes a lot of sense for the government to actually say, okay, you get screened, get that. If you're going to get, God forbid you're going to get it diagnosed early and get cured of it. So at least there is some way where we can actually prevent the magnitude of impact, the worst impact it has on society and people.
Doctor, I did visit the Tata hospital and I have had a personal story with cancer, of course. I saw many people from different walks of life.
Yeah.
India, I always say, exists in different centuries at once.
Yes.
We have the richest of the people and we have people who are, just about coming out of poverty. When you walk into a hospital like Tata, you understand one thing, that affordability gives you access, and access is inadvertently directly related to quality of life and longevity of life. If someone is detected with a chronic disease such as cancer. In this regard, I want to understand Why do you think we have a cap on insurance for chronic diseases? Because insurance, I think, is very, very vital. If the government really wants to do something, they should really make insurance available for people who have not had it, but after the diagnosis maybe can pay a little amount of premium, but can still get medical cover. What do you think about that? And is there a similar system in the UK?
It's a wonderful question, actually. And like we were discussing just a few minutes before on what can be done. Okay, so this is one of those many options that we've got. So let me tell you what happens in the UK. So the UK government supports almost everyone, unless you've got a corporate insurance or other things. It is mainly run by government. So NHS actually is in the news for bad reasons all over the world, but it is the best government run system anywhere in the world.
It may be draining the government dry.
It is great, and I'll tell you, I will come to that, because see, if you have a knee problem, you might have to wait for 6 months in NHS, but you will get it done. Okay, but if you got a cancer, the wait time is 2 weeks max. So the government has mandated. So the things are rationalized depending on the urgency. If it's something life-threatening, they have to take care of it. Now, because 95% of the people are covered, the government has to be prudent. One is, ethically, they cannot say no to a new treatment that has come into practice. But they will always do analysis of how it will benefit everyone. So they will not allow, if that there is only one patient of that condition in the whole country and it will require 1 crore of medicine, they might not allow. But if there are thousands of patients being diagnosed with the condition, they allow these drugs to be used. So you can imagine some of the drugs, such as immunotherapy drugs, that actually cost a fraction of what the cost is in UK. So it's almost 8 to 9 lakh rupees per cycle in the UK to give immunotherapy. The government would supply that for free for anyone regardless of their social status. If they are diagnosed with a condition and they are eligible, and the government and we as doctors believe it works for the patient, they can have it indefinitely. So crores and crores of rupees are spent on patients for drugs. Okay, but if the government feels that it may not work for the masses, there may be some restrictions. In the prior practice, you can use any drug that is approved and you think that works. But because of that uninhibited, or a kind of a difficult situation that this agreement has with people has put the government in, the government is actually spending too much on healthcare. And this is not just true for UK; it's for all the Western democracies. So the cost of the expense of treatment is extremely high. Okay, now you come back to India. So I'm a big fan of Tata's. Okay, so the vision that people who had set up Tata is amazing.
Correct.
Okay, now when patients go there, they go with some hope, because they built a name and a brand, because it was one of the first couple of them actually. There was one in Chennai, there was Kedway Memorial, and there was one in Chennai also, and then there was Tata. So Tata caters to almost everyone, whoever comes, and the mandate is they have to be treated equally.
Yes, and they are affiliated with MD Anderson, I believe.
I'm not sure if they are affiliated, but everyone, see, in oncology world, so I worked at Royal Marsden. So it is one of the oldest cancer hospitals in the world. So that is where a lot of drugs that we use were developed in conjunction with Institute of Cancer Research and Royal Marsden. So I worked with people who invented drugs.
Awesome.
So we wrote guidelines, not me, but as a whole team, that were followed all over the world. So what I understand is that when it comes to this kind of work, almost all the premier institutes in the world will work together.
Correct.
So they don't need a formal affiliation. But the problem that Tata faces is also the similar problem that the government face in Western democracies, which is the numbers.
Yeah.
So imagine if all patients with advanced cancer in the country decide to go and get the treatment at Tata. Tata is not going to be able to cope with it.
It is already overloaded.
It is overloaded. It is overloaded. Now, because of that, what I feel that it is really unfair of the society and the government to put all the burden on one or two institutes. So there are brilliant people in all walks of life, but also in the medical fraternity. There are amazing hospitals, brilliant people who should share this responsibility. And one of the things that you pointed out was about insurance. See, if you have to gift anyone, something, your parents or anyone, the best thing you can do is to give them the best insurance possible.
Absolutely agree. Absolutely.
So I have got amazing treatments, amazing options and weapons against cancer in my arsenal. But if I don't have the resource, I can't use it. Okay. So the cap thing is also something that the government has to look into, because many times what I feel, I'll tell you a very interesting thing. My mother recently got admitted for a pacemaker placement. Okay. And of all the people, her claim got rejected. So I don't know why. So I know a couple of reasons why they rejected the claim. One of them was, someone diagnosed her to have bronchial asthma, but there is no evidence. And I keep saying bronchial asthma. See, the diagnosis, sometimes, you go to a GP, they say, you have shortness of breath, it could be asthma. Okay. So there is no formal established diagnosis there. It has nothing to do with her heart condition. But they're still blocking. So the insurance companies are incentivized to block the claims.
Absolutely, yeah.
So it has to be the other way. It has to be a facilitator.
Correct.
Rather than
they should be incentivized to allow it.
Yeah. So anyways, so one is the quantum of insurance, and again allow the insurance company to actually be very pragmatic. So I'm sure they have to be very careful to avoid false claims.
Right.
But at the same time, in a disease like cancer, they should actually be facilitators and not create hindrance. And the other suggestion that you mentioned was also a very good one, which is, even if you get diagnosed with this, you can actually pay the premium, more premium, and pay it gradually. I believe there are those kind of schemes in that are
pipeline.
Provided, yeah, and they are provided by some finance companies rather than insurance people. I guess, if I'm not wrong, and I don't hold me to it, but I think Bajaj has a scheme where you can submit your documents and they'll pay for the treatment, and then you can pay them gradually, something like that. But it's more of a finance scheme rather than a insurance scheme.
Well, as long as there is an alternative for people who do not really have an option. Doctor, you have had the experience of working in the UK. You are working in India.
Yeah.
What is the one thing that is good with India in terms of medical care, frontline care, and what is the one thing that is good in UK, which India does not have?
So let me tell you what is good in UK that India doesn't have. It's a screening system.
Which you just mentioned.
Yeah, I just mentioned. So just being able to do that screening would save hundreds of lives. Okay. The second thing, what is good in India is, see, all of us, all Indians, we don't mind walking the extra mile. Okay. We'll do whatever it takes to help our patients. It doesn't matter whether it is 7 p.m. in the evening or 9 p.m. in the night. We'll be there. Okay. And when things move in India, they can move very fast. Okay. So you can have a PET scan, a biopsy, and commencement of treatment within 24 hours.
Correct.
Okay. And this is not without compromising the quality.
Correct. Okay. I don't think that is possible abroad.
That is not possible.
In fact, I'll give you an instance. I know somebody, they live in Canada, and we did this genetic testing in India for ourselves after everything that happened. But they just could not get the approval from their hospitals, their government, to get a basic genetic test done. I think this excessive red tapeism is where India is much better. What do you think?
No, you're right. And see, there are two sides to the coin. You are absolutely right. We can get those things. They are easily accessible. We can get this done. If they're going through the government system, there is going to be red tapeism. So that is what happened in the UK also.
Right.
But for my private patients, I was able to do it, straight away.
But then you have to pay for it.
You have to pay for it. You have to pay for it. But here also you have to pay for it.
But I think also because of the culture that the government pays for everything, you are more conditioned to rather wait than do it by paying yourself.
Yeah, so I think, we are used, you see, here when you are growing up here, you are used to private practice. Very few of us would go to government hospitals.
Correct.
Especially if you climb up the ladder and you are middle class and above, you will rarely go, unless it is absolutely necessary. But in the UK, everyone goes only to government hospital. Very few people go to private hospitals. So we are comparing a private practice in India to government practice in Canada and UK. So when I did private practice in UK, it was the same thing. You could do whichever test you want as long as the insurance covers, as long as the patients are willing to pay. So the problem with private practice abroad is anyone who goes there would know it can be extremely, extremely expensive. And
Correct.
when I say extremely, it is extremely expensive.
Like if a private doctor here would cost say 1,000 rupees for a consultation, how much would a person would charge there?
My consultation fee was 45,000 rupees
What are you saying?
for 15 minutes to 30 minutes.
How many bungalows do you have?
Oh, I don't have bungalows. But because the number of patients that you see privately, they're also restricted. You don't have a.
So it is.
So because everyone has access to government healthcare, so you can't have hundreds of patients. Otherwise, I would have had bungalows, and we would be doing this podcast there actually.
Yes, I would have enjoyed that. Maybe we would have come up with an insurance scheme of our own.
Yeah.
Doctor, with all of this, still, do you think even if we do everything, even if the government does everything in India, everywhere in the world, do you think the people would have enough trust in the system, enough trust in the treatment, enough trust in the process, medication, doctors? Because there's a lot of things that scares them.
Yeah.
Even if you have everything, for instance, there's a vaccine available for almost everything that used to be once, taboo to even think about.
Yeah.
But even then, there are a lot of people, there's a section of society, bunch of people who do not want to take a vaccine.
Yes.
So do you think trust?
So building trust is a very long process. You just cannot meet someone and just trust them. Then you'd be foolish, okay?
Correct.
Similarly, from the public point of view, building trust takes time. So when the public sees that, everything that is being done, there's a reason behind it. And if you do what the other person is saying, you always get good results. Your chances improve. Then gradually that impression builds up. You see, a lot of hospitals, doctors, that thing is built on trust. So even for us, for example, when I came back, I had to start from zero. So I was new to the city, new to town. And that building trust gradually takes time. And that only comes when more and more people interact, work with you and see what kind of service or care that you are giving, what kind of outcome you're getting. Okay. But on the other hand, for a hospital also, it is very easy for patients to lose trust. If they see there's something gone wrong with the billing, they would lose trust.
Correct.
And what my worry is now is that there's a lot written in the media about, how the hospitals are making money and, this thing. But I'd like to highlight this. Please go out of India
and just experience
experience. Okay. Now, it is expensive for us as compared to what we are earning. But you compare it to Africa, you compare it to any other comparable country, and compare it to the developed world also, we are actually very privileged because one, we have a lot of very skilled doctors,
right,
decent hospitals, some very good hospitals, but we also have our big pharma industry,
right,
that is manufacturing drug at a fraction of
the
cost.
cost.
What would happen there? So the trust has to be built slowly, gradually by the entire gamut of people who are in healthcare. It's not an individual's responsibility, and I think it's a continuous process. It's not like you build a trust and that's done. It's a matter of constant investment of time, effort, energy to get good results and do the right thing for the patients.
In your experience, and I was reading about what all you have done, you were heading something of a treatment called electrochemotherapy.
Yeah. I was part of the team. We did a very specialized way of treating some types of cancer with a treatment called electrochemotherapy, where you infuse a special type of chemotherapy into the bloodstream, and along with that you got 2 electrodes. They deliver electrical energy to the tumor.
Wow.
And that actually breaks the tumor open for the action of chemotherapy.
It primes it.
Yeah. So it works in both ways. One is a direct electricity, but also through the chemotherapy. So I've been trying to bring that to
India.
Mumbai. Okay. So you need it. I'm trying to build a team there. I've spoken to some of my colleagues.
Yeah, and the other thing was, I think, chrono chemotherapy.
Yeah. So chrono chemotherapy is.
What is that?
So there's a lot of research going on into what can you do that will allow the chemotherapy to work in a better way for our patients. Okay. One of the things that happens in human body is called circadian rhythm.
Yes.
Which is, there is a time for everything that is happening in the body. So certain hormones are released at one point of the day. Some hormones are released in the morning, some are in the evening. Similarly, we also have some evidence that the cells may actually proliferate at one particular time of the day, and they may be more aggressive and more proliferative in one time of the day and less in the others. Okay. So this idea of chronochemotherapy is to understand this rhythm of the growth of cells or cancer cells and give the treatment at the right time, not just bring everyone at 9 a.m. in the morning or 2 p.m. in the evening.
What is the ideal right time? When the cells are more or less?
Cells are more aggressive. Okay. And it is variable. Okay. So
is it individualistic?
Generally it is part of personalized care. So I believe in a few philosophy. One is personalization, precision, and goal-oriented and targeted therapy. So this is part of personalization. Systems don't accept it because you can't build a system saying, oh, you have to start chemotherapy right at 11 p.m. in the night. It will not work. But when you do hyper-personalized care, which I'm trying to do in my center, then you can plan it. Okay.
Wow. And you can do it for Indians, considering Indian demographics, Indian lifestyle.
Of course. But there has to be some deep thought and research. Before you start, you can't just say, okay, for this cancer you start 11 p.m. in the night. Okay, there has to be some understanding of.
You have to have the data of that person.
Yes.
Okay. Doctor, another thing which I have also experienced and learned through, my ordeal, I have seen that doctors work in silos. And when you go abroad and when we consult abroad, we usually see that the doctor says who all are there in your multidisciplinary board. When the first time I heard this, I did not understand what it really means, because it is quite unheard of for Indians. To have many doctors treating one particular illness is really not practical from an Indian's perspective. Why do you think it's still an alien thing? And do you think it is coming up, and can people have it or afford it?
Yeah. I did a very short survey on some of the patients. Okay. What I found is for the public and patients in general, a cancer doctor is a cancer doctor. They don't understand the difference between a cancer surgeon, oncosurgeon, a radiation oncologist, or a medical oncologist, precision oncologist like myself.
Right.
Because, these are very specialized area of work, super specialties, and you can't expect people to know unless they dealt with it. So the fact of the matter is, the tumor board or multidisciplinary team is the beating heart of a good cancer institute, because we all all educated people have the humility to know that they don't know everything.
Yeah.
Okay, there are very few people who are intelligent and educated and think that I know everything.
Well, that's actually hubris. You can't know everything.
Yeah, you can't know everything.
Yeah.
Okay, so I have spent 25 years of my life learning one skill on how to manage cancer.
Right.
I have a colleague who has spent 15 years of their life reading scans. Okay, and okay, I know to read how to read scans. I will be able to pick up an apple, but I'll not be able to pick up a pea.
Correct.
Okay, because my eyes are not trained for it.
that.
So I have to actually, if I see a scan, and if I say ये तो सब ठीक है, all clear है, but when it comes to a disease like cancer, every small thing makes a difference.
Yes.
So I should request my colleague who knows how to read nuclear medicine scan to comment on this, who says, oh, there is something, a small nodule somewhere which looks suspicious. And then I say, okay. And then look at it and say, it is too deep, we can't remove it, so let us continue the treatment. But what I should do is talk to my surgical oncologist saying, yeah, I think it is deep, what is your opinion? And he comes up and says, oh, we've got this new technique that has come up, we can do a bronchoscopically removal of this nodule.
Correct.
Okay. And I said, but that's a very rare thing, I read about it 20 years ago in my medical school, but I didn't know you could do that. And he says, yeah, we started doing it 2 years ago. Then he takes that out, and then we send it to the pathologist and says, oh, it looks the same tumor like before, but I'm not sure. But it is certainly the same thing. But the ideal thing would be, why don't we send it to a molecular specialist, a geneticist who understands the genomics? Let us do a genomic test. So at the end of the day, we bring all of this together, put it on the table, see what we're dealing with, and then my psycho-oncologist comes and says, oh, but the patient is feeling really terrible.
Psycho-oncologist.
Yeah. So there's a psycho-oncologist who looks at the psychological well-being of the patient. She says, I spoke to the patient, she is feeling very terrible and scared, and she doesn't want to undergo any treatment, but I'm counseling her.
Doctor, I'm going through oncologist since the last couple of years. I have not seen one psycho-oncologist.
Really?
Yes.
And you've not been offered?
Not really.
Okay. So that is very telling, because, doctors are tuned to do everything on their own, but we need to understand our limitations.
Right.
Okay.
That brings us to my next question. We were earlier speaking about the sheer numbers that a country like India has, in contrast to the countries in the West. We do have doctors. Some times ago I did some research after COVID, and I figured out that there's about less than a doctor for 1,000 patients in India, which is very, very disturbing.
Yeah.
So essentially a doctor has to see at least 20 to 30 patients in a day, right? Depending on what what is their discipline, what is their practice.
Yeah. Right.
How can they be so accommodative, right? Which actually is detrimental for the patient. Because when you go to a hospital, in India, most people, when you come in front of a doctor, when they come in front of a doctor, they are even scared to describe their illness. They don't know how to cross question. They don't know how to ask a doctor what the right thing is to ask, because they think the doctor is very busy. Oh, no. And we Indians have this, nature of accommodating the other, especially if the person is of authority.
Yeah.
So how do you think, as a doctor, you who have come from UK and now seeing the practice in India, how would a person like you cope up with it, and how other doctors should cope up with it?
See, you've given me a very interesting thing to think of, and an insight of how people might be scared to ask to the doctors, because at one point when we were growing up, doctors had that authority. Doctor would just scold you and say you have to get this done.
Correct.
Because sometimes we do want that, right? We want that person to be authoritative. When you need a vaccine, you need a vaccine. Okay. But to carry that forward when you are thinking independent adults is a bit of a thing that we have to move away from. Okay.
Right.
But what I have observed is majority of the patients who come, they will come with someone, a friend or a family member or a colleague, who would do the research on their behalf. Many times it would be the husband talking about the wife, or the son talking about the mother, and the mother would delegate all the responsibilities to them. And I insist that the person who is in question has to be involved in this discussion. Don't think that the other person would actually do whatever is right if you are able to think about it, unless you voluntarily want to do it. Time wise, it is a duty of every doctor to spend as much time as required by the patient to make the right decision. I'll give you a very interesting story about yesterday. So a young lady in profession of choreography, okay, she got diagnosed with breast cancer, and she said that I don't want to undergo any treatment, but maybe surgery, because it was a small lump. Had surgery, and someone said, you might need chemotherapy. But she said, I'm scared of chemotherapy, I don't want it. It is very bad. I don't want radiation therapy, I don't want hormone therapy. And then they suggested, okay, why don't you get this test that will tell us whether chemotherapy will benefit you. Okay, this is a test called Oncotype DX test. So she had that test with the hope that test will say that you don't need chemotherapy. But unfortunately, that test came back positive. So, I'm very new to social media. I just started doing something 2 months ago, because I gathered that, you have to get the word out, because there's a lot of misinformation there.
Correct.
So I have started this campaign of 1 rupee second opinion.
1 rupee second.
1 rupee. So second opinion for 1 rupee. That is because I don't want people to think I'm in this to, mint some money or anything. But it is really important that people who can access come and talk to me, and then decide what they want. So this lady found out about that. She came all the way from Andheri or Malad, I think. She came to see me in South Bombay, and I spent 1.5 hours with her, trying to explain what are the pros and cons of having treatment, what is right, what is wrong. And I told her, see, everyone has a right to make their own decision. Even if I think that decision is wrong, it is your decision. But you should make that decision based on the right information and the right data. Not just because you feel. That feel factor is something your body will, or it's a human tendency. We will always want to believe something that is more comforting to us.
Correct.
Okay? We don't want to go through the trouble. Okay.
Yeah.
So I spent 1.5 hours, and then she said, doctor, all done, thank you. I will think about it. I will tell you what I want to do. But now tell me, what is your fee? I said, it's 1 rupee. But doctor, you're kidding me. You spent so many years in the UK, you're giving me the valuable time. You must charge something. I said, no, I promised you I'll charge you 1 rupee. For the second opinion, it is 1 rupee. If you come down for treatment, then that is different. But this is the promise that you go. I think it is difficult. I will not be able to do that for every patient. But she had all these questions, and I personally felt that actually she was taking a wrong call. She is at a very high risk of relapse. She must have the treatment that is recommended to her. If not, she has a choice, but she needs to understand that the disease will come back. So I think in India what has happened is many people who've been working for many years have developed a following, okay, and then they run short of time. But that is where the tumor board and MDT comes into picture. So it is about organizing team so that doctors' time is freed up to discuss things with patients.
But with the kind of overload of patients that the doctors have, Say for instance, even if this 1 rupee second opinion thing becomes a hit and you get bombarded with...
No, I do get that. So I generally end up doing virtual consultations, but there is a lot of gap in patient's mind. Okay.
Of course.
So I'm not going to run it forever.
Of course.
It's just that I wanted people to have that ability to access the services and the knowledge. Okay.
Yeah.
So there is going to be overload. It is for us as professionals to figure out. I might say, okay, I'm going to see only 20 patients a day, but I'll see them well. I'll do the right thing, and I'll find a colleague who is equally good.
Yeah, but what I want to understand from you, doctor, imagine if you have an overload of patients and you have been doing it for a period of time, okay, and essentially the treatment remains more or less the same. You have to just, treat it, tweak it here a bit and there a bit. Does it become less about the patient and more about the treatment?
It's a very interesting question,
especially when you do it at scale.
Yeah, so there is a term called empathy fatigue, which means once you have crossed seeing 15-20 patients in a day, you become very mechanical.
Correct.
At the beginning of the day, you are very engaged with the patient, and it happens to doctors a lot and nurses too. And all of us doctors keep reminding ourselves that actually we are here for the patient, not for the treatment. We are the friend of the patient, not the friend of the treatment.
Or the pharma.
Definitely not. Okay, in fact, doctors and pharma have a very antagonistic approach to each other, by the way.
Which is very...
Pharma wants us to prescribe more. And doctors would say, only if it is necessary, you get it. Otherwise, you don't get it. Okay, that is what happens. But, so see, we have technology that we did not have before. I am hoping that when this podcast comes out, I will ask my patient, while I am doing something, why don't you see this podcast? You may actually already, some of the questions that you want to ask may already be answered. So there is a lot of information. Patients want it to be delivered through a doctor's mouth. So we'll have to use technology and different means to actually deliver that.
Do you think? But answering the question, do you think that the doctors can, somehow condition themselves to not have empathy fatigue, as you mentioned?
Yes. One is to have the insight. Okay. When you see a doctor writing on the table, not looking at the patient, just listening to the symptoms and writing things, that is the end of the day for the doctor.
So even body language is important.
Body language is important. If you're not engaging with the patient, okay, you're not paying attention to what they have said.
Because empathy has to be felt.
And doctors, majority of the good doctors do have an insight. And that is why you will see that doctors would keep you waiting but have a break, do something. And one good thing, you asked me earlier what is the difference between practicing in India and UK. One good thing about practicing in India is your life doesn't stop. Even when you are at work, you continue. You may have a friend who's visiting you. You may call a friend. You do something in between. So that is a way to actually cope up and give our 100% to the patients throughout the day.
For a person who's going through cancer in their cancer journey, what do you think is the lowest yielding phase? From the moment it gets diagnosed, the time the treatment starts, the follow-up, the affordability, or something else as a doctor? What do you think?
So if I understood correctly, you want to know what is the lowest yielding, as in the less happiest, the less productive phase of going through,
or the most horrible phase.
Yeah, I think one is when they get to know that it is cancer. It is still the case.
Is it the same for people in UK?
Everywhere.
The bad news is as bad news.
Because when someone tells you got a cancer, all you can think of is negative things. You only remember or think of bad things, think from bad to worse, and nothing else matters. People go through different phases of emotion. until they meet the right people and they see hope, because that sense of hopelessness of getting that news is, I think, the worst thing that happens to a patient.
As doctors, do you fear? Do you get scared for yourself if you get cancer, God forbid?
So doctors make the worst patients. We are the worst when we become patients for anything. Okay, because we, like I said, we also have a tendency to actually think of the worst things.
Even after your experience and
After
exposure.
our experience, okay, it is very different when you go through it or your family member. So for minor things, so for example, there are two things about oncologist, okay, and my wife will actually put a comment saying she agrees. If it is not cancer, we are not even worried about it, because everything else can be dealt with. We don't worry about migraine, we don't worry about headaches, chest infection or whatever. We know it can be taken care of. But when it comes to cancer, it is a very difficult thing, because we think of we don't think of the patients who we successfully treated. We sometimes end up thinking of the patient who did not do very well. So that there is a risk there.
Doctor, in major cities like Bombay, in Mumbai or Chennai, even Kolkata or some other cities, there are good hospitals, in terms of cancer care. And even some government hospitals have very, very, good care. We often see people from other states migrating for their treatment to cities, modern cities, metro cities. But at the same time, the people who live in these urban cities, they are less likely to go for a checkup, go for their treatment in these hospitals, and they end up diagnosing themselves at a very later stage. Why do you think there is this difference?
So I think some of us are like ostriches. We hide, we bury our head and we think all the problems will go away.
In the sand.
Okay. And you might be experiencing symptoms. People might be experiencing, I've been losing weight for unexplained reason. I've been smoking and I've got something in my throat and I'm just ignoring it. So because I don't want to know the bad news, so I'm delaying that hit of bad news, and that only makes things worse. Okay.
So what are the most commonly ignored signs that you have noticed in your patients?
Blood coming out from any part of the body.
People avoid blood coming out of their body.
Yeah. So if they got a blood in the poop or urine now and then, for example, they might just ignore it. If they've coughed up blood a couple of times, they ignore it. The second thing is they ignore constant cough. People have long-term cough, they ignore. People ignore weight loss. Some people also ignore lumps and bumps in the body. Some people think, there is a lump, but it will just go away magically. So these are few very common symptoms of cancer.
Okay.
And people just seem to think, they ignore it. See, one very unfortunate thing about human psychology is that we think that the bad thing is only going to happen to the next person. Nothing bad is going to happen to me.
We are invincible.
But unfortunately, we are all in the same grind. We are all vulnerable. We are all at risk.
And in your experience, ये क्या सिर्फ एक certain society से related है, class से related है, ethnic background, financial capacity? Is it related to our social stature that our mentality tells us कि नहीं, अगर lump है तो कोई बात नहीं, अगर cough में blood आ रहा है तो कोई बात नहीं, or even it is there in the upper classes, middle classes and the lower classes?
यानी ये बहुत अच्छा सवाल है, इसलिए कि हम लोग कई बार ना सोचते कि यार वो ट्रीटमेंट नहीं हुआ क्योंकि वो गरीब था, या ट्रीटमेंट नहीं हुआ क्योंकि उसके पास एक्सेस नहीं था. बट ऐसा कुछ नहीं है. जैसे मैंने आपसे पहले कहा था कि स्क्रीनिंग के लिए अगर आप कितना भी आप प्रमोट करोगे तो गरीब हो या अमीर, उसका मेंटालिटी एक ही है कि यार जब होगा तब देखा जाएगा, अभी से क्यों पता करो। ठीक है, तो कई लोग हैं जिनको जो बहुत हेल्थ कॉन्शियस है वो करना चाहते हैं तो शायद अफोर्ड नहीं कर पाएंगे, एक्सेस नहीं है, बट मेजॉरिटी लोगों का ये सोचना है कि जब होगा तब देखा जाएगा, अभी से पता करने की क्या ज़रूरत है। अगर कुछ हो भी जाएगा तो वो अपने आप ठीक हो जाएगा। दूसरी एक और चीज़ ये भी है ना कि आजकल मैं और एक चीज़ देख रहा हूँ कि बहुत से लोग ये जो अल्टरनेटिव मेडिसिन और पैरेलल थेरेपी, जो अल्टरनेटिव थेरेपीज़ है, इसके नाम पे बहुत से लोगों को बेवकूफ़ बनाया जा रहा है, क्योंकि जेन्युइन अल्टरनेटिव मेडिसिन के प्रैक्टिशनर्स अच्छे जो है बहुत कम है। ठीक है, गवर्नमेंट और सरकार प्रयास कर रही है कि उस फील्ड के भी अच्छे लोग डेवलप हों, बट वैसे बहुत कम लोग हैं, और उस चक्कर में ना जो मिस इन्फॉर्मेशन जो फैल रही है उससे बड़ा नुकसान होता है पेशेंट, क्योंकि उसमें आप आना जाना करते हैं, समय जाता है, और जितना समय अगर वेस्ट होगा उतना ही डिफ़िकल्ट होगा कैंसर को ट्रीट करना, उतना ही मुश्किल होगा।
पर ये माइंडसेट हर क्लास ऑफ सोसाइटी में है कि कोई बात नहीं, लेट इट बी, जब होगा तब देखा जाएगा।
देखिए यार, क्लास, अब देखिए हम लोग सब लोग इंडिया में सब लोग किसी गांव से आए हैं।
राइट,
सब लोग किसी गांव से, 2-3 जनरेशन पहले अगर आप जाओगे तो सब, अभी भी पूछो आप किसी भी अमीर को आपका गांव कहाँ है, साउथ बॉम्बे में भी आप पूछोगे तो राजस्थान में कोई गांव मिलेगा।
एब्सोल्युटली।
ठीक है, यहाँ भी आप पूछो तो कहीं ना कहीं सब लोग, हम लोग वी आर कमिंग फ्रॉम रूरल एरिया, मोस्ट ऑफ अस, हम लोग अभी भी उस माइंडसेट में हैं।
सो फंडामेंटल मेंटालिटी सेम है,
मेंटालिटी सिमिलर है। इट्स नॉट अबाउट अच्छा बुरा नहीं है, बट हम लोग वी आर जस्ट द सेम, मेजॉरिटी ऑफ अस। ओके, कुछ 5% लोग होंगे थोड़े डिफरेंट, बट ये एक कॉमन ऑब्जर्वेशन है कि लोग थोड़ा ओवरलुक करते हैं, इग्नोर करते हैं, और मिस इन्फॉर्मेशन में जल्दी बिलीव कर लेते हैं।
या बिकॉज वो कन्वीनियंट होता है।
कन्वीनियंट होता है, एग्जैक्टली आपने जो बोला, क्योंकि देखिए लाइक आई सेड ना, हमको कोई भी चीज़ का आसान जवाब चाहिए।
करेक्ट करेक्ट करेक्ट।
कि आप ये एक काम कीजिए, ये क्रिया कीजिए, या ये फल खाइए, और इससे आप,
आई डोंट डिनाई कि उनका इफेक्ट होता है या नहीं होता है,
नहीं वो एक अलग चीज़,
वो अलग डिबेट है।
उसमें देखिए आप, उसमें कैसा होता है कि 100 अच्छे या 5 अच्छे लोग और 95 लोग जो वो 5 अच्छे लोगों के रेपुटेशन से खेल रहे हैं, वो लोग होते हैं।
और डॉक्टर, व्हाट आई रियलाइज इज, सेहत के लिए कुछ अच्छा होना इज़ वन थिंग, पर बीमारी का इलाज होना इज़ अ डिफरेंट थिंग।
हाँ बिल्कुल, और आपने जो अभी बात की ना कि स्टेटस, सोशल क्लास से क्या फ़र्क पड़ता है, मैं तो इंडियन की बात कर रहा हूँ। स्टीव जॉब्स को जानते हैं? स्टीव जॉब्स को पैनक्रियाटिक कैंसर हुआ।
राइट।
और स्टीव जॉब, कौन ऐसा दुनिया में जो बोलेगा इंटेलिजेंट नहीं है?
एब्सोल्युटली।
क्या उसको पैसे की कोई कमी थी?
नहीं, एटलीस्ट आफ्टर बिकमिंग द CEO, फाउंडर,
उसको आफ्टर बिकमिंग द CEO कैंसर हुआ था।
आई नो,
बट क्या किया उसने? कैरेट जूस, ऑल्टरनेटिव थेरेपी, उसके लिए भी काम नहीं किया, क्योंकि ही वॉज मिसलेड।
राइट।
तो इफ ही इज वल्नरेबल, आई बिलीव ही इज समवन हु हैड अ क्रिटिकल माइंड
एंड ही हैड एक्सेस टू
एवरीथिंग, ही फेल प्रे टू इट। तो सभी लोगों के लिए
Michael Jackson died of a similar thing, like
he died of propofol,
medical carelessness. There is this other actor also, anyway.